All right, good afternoon, good morning, everyone. Thank you so much for joining today's webinar. We will just give a couple moments for some more people to join, and then we will go ahead and get started. All right, so since we are just a couple minutes above the hour, apologies for the delay, but we appreciate you all being here. So we will go ahead and get started. So good afternoon and good morning. Hello, everyone, and welcome to today's webinar, which is hosted by the Coalition Against Hepatitis for People of African Origin, or CHIPO. My name is Beatrice Zovich, and I'm a Public Health Program Manager at the Hepatitis B Foundation and the manager of the CHIPO Coalition. Thank you all so much for tuning in today. Today's webinar is centered around the work and research of Dr. Maurizio Bonacini at the California Pacific Medical Center Research Institute in San Francisco, who will be providing an overview of the latest literature on hepatitis B and Delta in African immigrant communities in the United States, as well as elsewhere in other countries that have high numbers of African diaspora folks. And his presentation will include how the epidemiology aligns and intersects with different social and demographic trends, as well as and he will also be discussing effective strategies for addressing some of the disparities and conducting outreach to some of the most impacted communities to improve screening, prevention, and linkage to care for hepatitis B. So we're very much looking forward to a great presentation today. Next slide, please. So before we get started, just a quick note about using Zoom webinars today. So just like to remind all participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. If at any time during the presentation you have any questions, you can feel free to enter them into the Q&A box, and questions will be addressed by Dr. Bonacini at the conclusion of the presentation. And the session is also being recorded, and the presentation will be shared with all webinar registrants following today's event. Next slide, please. Thank you so much. So before we get started, just a little bit of background about CHIPO. So again, this is the Coalition Against Hepatitis for People of African Origin, and this is a community coalition co-founded and led by the Hepatitis B Foundation. We are composed of organizations and individuals who are interested in addressing the high rates of hepatitis B among African immigrant communities in the United States. CHIPO serves as a forum for sharing information and best practices and improving capacity nationally to increase hepatitis B awareness, testing, vaccination, and linkage to care among highly affected African communities. We currently have over 50 coalition members from across the United States. Next slide, please. Thank you. So today we are very excited and honored to be joined by Dr. Maurizio Bonacini, who is a hepatologist and researcher from California. Dr. Bonacini pursues clinical research in liver fibrosis, drug-induced liver injury, hepatitis B and C therapies, and C. diff infection as well after liver transplants. He is a principal investigator in studies investigating the influence of HIV infection on chronic hepatitis B and C co-infection, as well as efficacy and safety of new therapies for hepatitis B and C, and hepatitis C persistence and pathogenesis. And he is also beginning work on addressing hepatitis B in the African context and serves many immigrant communities in his current practice in San Francisco. So we're very excited again to hear from Dr. Bonacini today, and we're grateful to him for joining us. We invite audience members again to put any questions that you may have in the Q&A box as they arise, and they will be addressed at the conclusion of the presentation. And we also hope to have a robust discussion about effective outreach following the presentation as well. So without further ado, I invite Dr. Bonacini to begin his presentation, and thank you so much.
Thank you, Beatrice. I have to find a way to share my screen. Oh, here we go. Okay, sure. Let's see. Share. And do you see the first slide?
Yep, Looks
Okay,
perfect.
so we have it. So, well, I'm not going to pretend I'm really big expert in immigration. I do have some patients from Africa with hepatitis B, and I'm trying to sort of expand my horizons by reaching out to immigrant communities. So, in response to Beatrice's invitation, I just reviewed the more recent literature to give us a little bit of a newer perspective, perhaps, on immigration and how it relates to hepatitis B and Delta. Um, so let me see, maybe this will make things advance. So this is my research support. I'm on the speaker bureau for two companies, but this has nothing to do with hepatitis B. So these are basically my disclosures. So I started by looking at the WHO strategy to decrease the burden of the disease, because at the end of the day, that's our goal. And basically, they mention vaccination for kids. In this regard, when I look at the pentavalent vaccine that is distributed at week 6 after birth, this basically in every country that I looked at it's been pretty successful. I see numbers that range from 70 to greater than 90% vaccination rate. So we're doing pretty well there. Vaccination of adults is probably very different. There is a current recommendation to have adults vaccinated in the United States. I'm not sure where we are at in the United States or elsewhere. The fact that mother-to-child transmission of hepatitis C needs to be controlled, it's a very important thing, and in fact, it's a goal that's very dear to me. Unfortunately, I'm sorry, many hurdles which I'll not discuss in this presentation. There's also the issue of safe sex practices, which is clearly a mode of transmission in Western countries. And last but not least is the fact that we really need to do a better job at identifying patients, as I will show you in the next few slides. So because we're talking about immigration, I just went to the United States Immigration and Nationality Act, and I found that there is a requirement to submit documentation of vaccines. You see several bacterial and viral viruses that are mentioned to show vaccination, and hepatitis B is one of them. However, there is nothing written in the Nationality Act that patients need to show whether they are positive or negative to hepatitis B. So a person could carry the hepatitis B virus, showing vaccination. Of course, vaccination doesn't do anything, neither good or bad, and the patient miss out the opportunity to be told whether they have hepatitis B or not. And for the sake of completeness, all these are the other vaccinations that are required to immigrate to the United States. So, in view of this, I thought...
Dr.
Yes.
Bonacini, I'm so sorry. Is there a way to turn your volume up a little bit? I think you're just a little hard to hear.
Sorry.
Yeah, that's okay.
Why do I do that?
If you go, sometimes if you just go on your keyboard to turn on the upper left, you can turn the volume up, or you can also turn it on your computer. There should be a microphone button in the lower left.
Yes. I have one and the other on the right is 100%. Can you hear better if I speak louder?
I think that's a bit better. Yeah, it might
Better.
be. Yeah, if it's up to 100%, then I think if you could just speak a little louder, that would be much appreciated. Thank you so much.
Yes. So I'm sorry about that. You still see the slides?
Yes, if you just want to go back to, now I think it's now it's in your, it's not on the slide. So I think if you go back to them, yeah, if you just go back to PowerPoint at the bottom. Yep. And then perfect. If you just go back to slideshow and present. Great.
Okay.
That's excellent.
So interrupt me again if you cannot hear well. So I'm trying to
I think
speak
that's
louder.
better.
So we're going to talk about data from the USA. Then I'm gonna show you a few slides on data on African immigrants to the United States, then data on African immigrants to other countries, and then some data from the African continent itself. So in the United States, it is thought that the prevalence of chronic hepatitis B is about 0.5%, but in reality, we don't really know. The totals in the literature vary widely from less than a million to 2.4 million. And the reason for this is it's because the CDC estimates that about two-thirds of patients are actually not aware of their disease. So the number aware of the disease is only 32%. As we know, the Asian population carries an excessive burden of hepatitis B, and Asian patients are, so Asian individuals are about 6% of the total population of the United States. However, in some counties, such as San Francisco, where I work, or in Alameda County, which is the county directly across the bridge, 35% are Asians. And so, of course, this can give you different percentages. So I wanted to show you these numbers because they were put out by the Alameda Public Health, and that's an outfit that we are trying to collaborate together to create more awareness, more case finding here locally to achieve what we hope to be micro elimination of hepatitis B. And this was a recent study published 2024. They looked at the prevalence of chronic hepatitis B defined by two positive tests for hepatitis B surface antigen. And the prevalence was essentially 0.5%, which mirrors the estimate for the whole US. Interestingly, they did not find any difference between male or female, and particularly, they didn't find any difference in women of childbearing potential. There was, however, differences in the ethnic background of the population. So 1.2% prevalence in Asians, 0.6% of patients of Hawaiian origin, and African Americans and white and Latinos have significantly lower risk of being found hepatitis B surface antigen positive. There are a couple of things here I thought were interesting because you see they will be matched by data that I'll show you from Africa, where patients between the age of 30 and 69 had higher chance of being found surface antigen positive versus either the younger ones, so less than 30, probably reflecting recent or relatively recent birth vaccination and adolescent vaccination. And the 70 plus had actually lower chance of being surface antigen positive, so 0.3% versus almost 0.9%. Further, they divided the population into high HPI. So HPI is a healthy places index. So it's essentially a way to assess the affluence, so the socioeconomic level of the population. There are 4 levels, and I chose to put together the 2 highest level and the 2 lowest levels. And you can see that in the lower socioeconomic group, the chance of being found surface antigen positive was 50% higher than in the more affluent populations. The other thing that was interesting in this study is that they look at follow-up hepatitis B tests within 399 days, and they found that essentially the follow-up is not very good. And as I recall, in other CHIPO meetings and data from, presentation from Africa from the HBV Foundation, this lack of follow-up is also a hurdle. And so it is a hurdle in Africa, but it's also a hurdle in the United States. As you see here, patients that actually the recommended annual hepatitis B test, so for e antigen or DNA, they put them all together, was only 22%. That means that almost 80% of people don't have an annual test as it is currently actually recommended by guidelines. So let's move on to data on immigrants from from Africa actually. And in this particular study came from the Bronx, and they invited, essentially what they did, they went to for giving educational events in places of worship, some mosques and some churches, and they educated patients and invited them to be tested for hepatitis B. And I'm sorry here, this didn't make it, but 173 patients were negative and were offered vaccination. And they found that 13% of patients declined. So it's not obvious that every patient will accept vaccination, as we all noticed with the recent COVID pandemic. Also, of the 87% that accepted vaccination, in fact, only 72% started. So we lose a few patients from the transition from agreeing to be vaccinated to actually start the vaccination series. And almost 90%, though, finished the series, which I think is a pretty good success for finishing the 3 injections. Now, according to the authors, the key issue in being able to recruit a significant amount of patients and get the majority of them vaccinated was actually the enrollment of 3 West African medical professionals. They recruited patients after this educational event, basically pointing out to the fact that you need to resonate with the community and have a credible presence in the community you're trying to educate and engage with clinical care. The same group did also what I thought was an interesting study. This study doesn't give so much quantitative data, but more qualitative data on the perception of hepatitis B in immigration communities. So they did 23 in-depth interview after this program that was called the Starfish program. As you can see, there was almost evenly divided women versus men. Now, some of these patients were surface antigen negative, some of them were positive. They wanted to know how they perceived hepatitis B in general. The average age of the patients enrolled was 49 years of age. They were paid a very modest gift card compensation. And what is interesting to me is that when they asked for knowledge of transmission of disease, the majority were not very clear on transmission. I think that
Dr. Bonacini, I'm sorry,
yeah.
if you could just speak louder still and just try to maintain the volume. Sorry. Thank
Sorry,
you.
my voice is trailing off. I don't know. Maybe this set is not very good. So I was saying that in terms of knowledge, they were not very clear on the transmission. Some patients didn't think that it could be transmitted by sex or by mother-to-child transmission. Some thought that it could be transmitted by casual contact. So the knowledge clearly needs to be improved. They next assessed the stigma, and they found that the majority of patients that were positive in this study, some of these patients were positive, were actually uncomfortable discussing hepatitis B outside of the immediate family. Interestingly, there was also a significant difference in the way healthcare was perceived in the United States, but this was in a positive sense, in the sense that there was more trust in the USA healthcare, and they felt also the providers were more likely to be listening in the United States rather than in their native country. And I think the important finding that family and friends were felt to be very important for both knowledge and healthcare referrals. Now, knowledge could be a double-edged sword because you may rely on the knowledge of some people that may not actually be very knowledgeable. But I think this would be important, in my view, to further leverage our impact on patients that have hepatitis B or they're negative, to be sure that we expand the sort of the approach that we can have to these patients. Sorry. So now let's talk a little bit about what happens to African immigrants in other countries. And I thought there were 2 very interesting studies. This one was actually done in Libya. There was a hospital checkpoint in a city in Libya called Al-Kufra, where immigrants are tested after informed consent. So if you don't know the immigration pattern from Africa, often the individuals are funneled through the Libyan desert. They end up in Libya, sometimes in Tunisia, although I think in Tunisia there are stricter rules, because from Tunisia, for instance, you can go to Italy. The first stop would be an island called Lampedusa, which is only about 75, 80 miles from the Tunisian coast. So clearly there's a lot of migrants that go through this path. And they were able actually to test a large number of patients, so 3,248 migrants from sub-Saharan Africa. And of those, 58% were Central Africans, 28% from West Africa, and only a minority were from East Africa. As you can imagine, the vast majority here were male, But what I found shocking is that the surface antigen test was positive in 24% of males and 10% of females. And what they showed, if you remember the data from Alameda County, that in older patients 40 or above, the percentage of surface antigen positive was actually lower, which was a little not expected in my view. Now, if you ask the question, what kind of test they used a point of care test. It was a China-made rapid test for surface antigen, but they all were confirmed with an ELISA test, which is also was a made in China type of kit. And I found these numbers really astounding, and I hope they give the correct number because this seems really, really high. From East Africa, even though it was a minority of the migrants, 55% tested positive. From West Africa, 36%. And the lowest percentage of surface antigen positivity was 10% in Central Africa. Compare this with what I showed you in Alameda County, just 1.2%, even in high-risk populations such as the Asian community. And also, for good measure, I wanted to throw in the data that they found on hepatitis C antibody, where the percentage was also very high, but here they didn't give data on RNA. So all we know is exposure to hepatitis C was 66% in East Africa, 54% in West Africa, and only 12% in Central Africa. And here I found it interesting that the male-female prevalence was actually flipped, where you had more females that were positive for the anti-HCV versus 31% in males. So this data also in immigration individuals in a holding area in the Emilia region of Italy. So this is a part of northeast Italy. They have some requirements that these immigrants are basically housed in some facilities pending court orders about admitting them to Italy or sending back to the native country. And they evaluated 454 patients from Africa and 85 patients from Asia. Now, keep in mind that these patients were not from the Far East, so we're not talking about immigrants from China or Korea or the Philippines. Mainly, these patients were all from Bangladesh, Pakistan, and Afghanistan, essentially. And here's the other numbers. Here they divided between all hepatitis B test positive, so that includes a positive core antibody. And here the second line is patients, individual positive for the hepatitis B surface antigen only. And as you can see, all tests positive are about the same, between 22 and 29%. Whereas for the surface antigen positives, you see that number is significantly lower in Asian patients versus Central and East Africa patients versus 6% in West Africa. So the numbers, I think, are more believable than what we've seen from Libya, and I'm not sure I can give you an answer why that is. And we see these numbers will be fairly well validated in the next few slides. Then I wanted to throw this study, and it's really different. It has to do with migrant children, which 96 were from Africa and 17 were from Asia. This was not a compulsory evaluation like in the Italian studies. These were voluntary parents that bring voluntarily their children to be tested. And out of this 132 migrants, no child had hepatitis B, none had hepatitis C, and none had HIV, which I think was interesting. However, they did find that 5% were positive for tuberculosis. And I think the Hepatitis B Foundation has a talk coming up just after this one that speaks about the intersection between tuberculosis and hepatitis B. So I will not mention this further. I want to show you this data from Africa. There are two meta-analyses. They're both from last year, so really hot the press. However, each study is sort of different studies. I'm sure there's a significant overlap, but one author chose 90 studies, the other one 124 studies. Remember, these studies sort of, because it's a meta-analysis, captured data that can be decades old. But they found in terms of surface antigen, and here I stress, it was only surface antigen positive patients, And you can see they're pretty comparable, but chiefly because there is most likely significant overlap. But you can see there seems to be a gradient from West Africa to Central Africa and then to East Africa with decreasing rates of hepatitis B surface antigen positivity. So from 10 down to 4 to 5%. I found it interesting that both in South Africa and North Africa, the numbers is lower yet. So we're talking about 2%. So, and these are blood donors. So I would throw in some assumptions that we're healthier patients, probably I would guess of a high socioeconomic status, and we'll get into that in a few slides. I wanted to show you some data on some specific studies. This, I believe, it was from, I'm sorry, from Nigeria, from Abuja. They had a screening fair, and you see they were able to contact significant amount of patients, 3,245 patients, 62% being female with an average age of 35. They do the pinprick screen, but they also got some blood draw for later testing after informed consent. And you see that the number of surface antigen positive here is sort of lower. It's 3.7% in female, 5.4% in male, so the average being close to 4 to 5%, similar to the data that I showed you on in the blood donors. And here they found this thought to be a recurrent theme, right? That the older population, just like in the Alameda County here, had the lowest chance of being surface antigen positive, 0.5%, and the highest was in the younger population, 20 to 39. And you wonder here how effective the week 6 pentavalent vaccine has been, at least in this particular locale in Nigeria. Those that tested negative for surface antigen were asked to undergo vaccination. As you can see, 77% agreed, which is actually a little lower than in the data from the Bronx, and only 44% received all the 3 doses of the vaccine. So clearly there is room for improvement here as well. These numbers come from Arusha in Tanzania. This was a study was headed by one of my colleagues, Jose Debes, who has been from University of Minnesota, who is very active in Arusha. So Arusha is a small city very close to Mount Kilimanjaro, and they perform screening days in multiple clinics, spending 6 to 8 hour days getting patients to be tested. Again, they define hepatitis B as a surface antigen by quick pinprick examination of blood. They also got point-of-care ultrasound in these patients. So the number was a little lower, but they evaluated 501 patients, 63% women, age 40. So it looks like what the same sort of age, gender makeup than in Nigeria. And again, this is also very recent, 2024. And they found the percentage of positivity was only 2 to 3%. And there was no difference between men and women. So it's even lower than in Nigeria. And in fact, really at the lower end of the data that I showed you for blood donors. They asked several questions about household income and household scholarity. They did find the only positive correlate was a fourfold chance of being surface antigen positive if there was a positive household contact with hepatitis B surface antigen. And they did find that one patient had a liver mass. Now, they didn't find what was a benign tumor or malignant tumor. And another patient, different patient, had ascites. So the number, of course, was small. And only 6% of these patients are reported to have had the hepatitis B vaccine. So clearly, or here as well, there's some room for improvement. I wanted to look at the healthcare workers. This was an interesting meta-analysis that was just really released this year, so very recent. And the reason why I was interested in that because several of my connections here are from African patients that are working in healthcare here in the United States. This meta-analysis defined, unfortunately, hepatitis B as a mix of surface antigen plus or minus core antibody. So either evidence of active infection or exposure, past exposure. And they also divided these healthcare workers into West Africans, Central Africans, or East Africans. And these are the numbers. Highest in West Africa, there seems to be now a recurrent theme. And here was a little bit flipped because there was, as opposed to blood donors in East Africa, the numbers were higher than Central Africa. Uh, Something interesting was that the stronger risk factor for being surface antigen positive was to have a known history of chronic liver disease. They didn't specify how chronic or how severe, and also age greater than 40. So this goes a little bit contrary to what we've seen in the past, and I'm not sure I can get my finger on the why the difference. They also found that working in a private facility versus a state or public hospital was that there was a lower prevalence of hepatitis B in the private facility, although that was borderline significant, actually not quite significant. So I thought it was interesting set of data. And finally, because I think it's important to realize that there are so significant socioeconomic sort of variables here at work, I want to show this study that was done on in Turkish patients. So they took all patients that tested positive for the hepatitis B, so all surface antigen positive. A number of them were Belgium or Netherlands born, so they were immigrants, so children of immigrants to Belgium, and others were Turkish born that immigrated to Belgium. And as you can see, I'm sorry for the misalignment here, that in the Belgian born cohort, only a third of patients were deemed to have, in quote, low socioeconomic status, whereas almost double the percentage socioeconomic status was found in Turkish-born chronic hepatitis B patients. And the corollary of this is that cirrhosis was more frequent in Turkish-born patients, and HCC and liver decompensation was also more common in Turkish-born patients. So when they look at multivariate analysis, it was not so much the being born here or there, is the fact that low socioeconomic status was associated with about sixfold the risk of cirrhosis. So I think that's very important. And I think important in this study was the discussion that the authors gave us, suggesting the low socioeconomic status is associated with low health literacy, less opportunities for medical follow-up. If you need to work two jobs, for instance, I can easily imagine people will not go to a doctor as readily. Potentially a low level of sexual precautions, although they didn't really prove the point in their study, and the possibility of a high chance of childhood infection. That means the longer you've been infected, the more of a chance you have to have more significant liver disease as follow-up. So I'm going to give the last couple of slides on hepatitis delta, which is, I mean, if we think that hepatitis B is not well sort of known and understood, delta is even less so, even in resource-rich countries where the testing for delta is really much, much lower than it should be. So I found that in Africa, there was significant variation in delta antibodies that vary from nearly 0% in Eastern South Africa to 26% in Central Africa. Actually, here, I'm sorry, this got cut as well. In Tanzania, for instance, we have a special interest in the country. It's supposed to be about 5%. So 5% of patients with hepatitis B will test positive for the antibodies. And a few studies that really look at HDV RNA suggest that percentage positive viremia runs about 60 to 70%. So I'll show you the last two slides, the two data that actually I cannot see the top. This was actually from Chad, from Jamena. They looked at 94 store sera for well-pedigreed patients with surface antigen positive. There were students, and some of them were pregnant women, students at the local university. So what they found is that delta positive were 11% in men and 9% of women. There was no detail in the risk factors for these patients. Where, for instance, in the United States, injection drug use is a big factor. I'm not sure at all that this is true in Chad, but they didn't mention that. What they did find that in the positive delta antibody positive, about 78%, so three-quarters of them were viremic, and a quarter, of course, was not viremic. The viral load on average was 2.63 logs, and they found that genotype 1 was most frequent. They didn't show any data on liver fibrosis. This other study shows 914 patients. I believe this was from Senegal. Um, and of those, 117 were co-infected HIV hepatitis B. The majority of these patients, except the HIV patient, were naive to medication, so they were not on any entecavir or tenofovir. And of those patients, 15% from the get-go were negative for hepatitis B DNA. When they look at the delta positivity, was much lower, only 13 patients or 1.4%, so much lower than the Chad study. And delta RNA was positive in 8 of these 13, so 62%. So as I told you before, maybe two-thirds to three-quarters of patients with delta antibodies will actually be viremic. The genotype was different, 75% at genotype 5, and I'm not very familiar with that genotype. The median HDV RNA was 3 logs, less, just like the other study. And of those that were delta positive, 4 out of 6 had undetectable hepatitis B DNA, and they were 18-fold more likely to have a KPA 12.5 that's supposed to be at least stage 3 fibrosis by FibroScan. So the fact that you're delta positive is obviously associated with more severe liver disease, and we know it's more associated with liver cancer. So this is my last slide. In conclusion, I would say that hepatitis B in individuals of African origin is more common than in the US. However, the prevalence varies significantly according to region, and probably we will find it in a single country, probably very significant from area to area. The prevalence may also vary by socioeconomic strata, I hope I showed you. And then delta hepatitis has been insufficiently studied, and I think that barriers to both testing to identify patients at risk or infected and vaccination need to be identified. So those barriers need to be identified and lowered, and that is true worldwide. So if you have any question, please put them in the chat or unmute.
Thank you so much, Dr. Bonacini. We really appreciate this presentation. Apologies for the volume issues, but I think if we, when we put the recording up, we can try to adjust that as well. So if anyone has any questions, please feel free to put them in the Q&A box. But we really appreciate this great overview of different epidemiological trends for Hep B and Delta among different communities. I can start off with some questions. So you had noted a few times that older adults have both in Alameda County and then I think elsewhere internationally actually have lower prevalence and incidence of hepatitis B. So I was just curious if you could speak a little more to that, or if you have any insights as to why, especially folks over 70, might have lower incidence.
Well, the short answer is that I don't know. By the way, can you hear me a little more now that I have the mic
Yeah,
closer?
that's better. Yeah.
Okay. So I think it's hard to make inferences without knowing the mode of transmission. We know that in Africa, in Asia, mother-to-child transmission is quite important, but the other modes of transmission, sexual transmission is a reality. Transmission with contaminated dental instruments is a possibility too. My take is that older patients may have had less of an exposure. Could it be question mark sexual? I think over time we probably, and I'm guessing here in Africa, we must have improved, just like in the United States, how should I say, the rate of transmission by transfusion. So I'm not sure how they were really a lower risk. So I cannot really tell. Um, because most of the study were not really granular into their risk. Can we
Mhm.
say maybe younger patients recently have been more sexually active without protection? I don't know. I know that in Africa it's there's large difference. Like for instance, in Uganda, they've been exceedingly successful in stemming the HIV epidemic by pushing the concept of safe sex. Other countries lag behind. So there's a lot of heterogeneity. So I think I'll stick with my first answer. I'm not exactly sure, but I thought it was
Yeah.
interesting epidemiological observation.
Yeah, absolutely. That's good. Yeah, no, I think that those are good theories, and that's important. Just an interesting note. Um, and then I think it was interesting too, the discrepancies between East and West Africa prevalence and how they were kind of flipped in the studies in Libya, and then in among healthcare workers as well. Um, yeah, just if you a lot of the studies that you had showcase the differences between East, West, and Central very well. So just if you have any thoughts on if it was a particular group that that was studied, or just or if it was different points in time, or what might have led to the different regional um, differences.
Well, it is very interesting. Apparently they found hepatitis B DNA in mummies from Egypt. So I'm sure there's something to do about, first of all, this virus is extremely old, how patients or individuals have migrated throughout Africa. And I'm not really a specialist in that. Maybe I wanted to give an aside. Nobody asked the question, but I was surprised in the study that I showed you from the Bronx, the ones where they asked patients about stigma knowledge. I was expecting sort of knowledge to be suboptimal because there's a lot of misconception about a lot of medical things. But also, the hypothesis of the authors is that about the stigma issue, if patients have known more about mother to child transmission and so not sex, they have basically hypothesized that the stigma would decrease if you would say, okay, I got it just like I got diabetes, it's genetic. If you get it from your mom, then the stigma may decrease. I think that was an interesting observation about the knowledge, and I didn't want to present the data here because we're talking essentially about Africa. There was a recent presentation in Amsterdam about a Chinese group. They looked at several thousands of patients, and they found also that knowledge in a country that more resource rich, say, it's a more middle income, right? That the knowledge would be higher. Well, it wasn't. Still, people were
Mm.
not very knowledgeable about transmission by the disease cannot be transmitted by casual contacts. They didn't know about mother to child transmission. So I was surprised that this lack of awareness is not about Africa, it's about everybody. The whole world, I think, is behind and a number of viewpoints when we talk about hepatitis B.
Yeah, absolutely. I think that's a very good point. And yeah, very, very important to make sort of common ground among all different groups that might potentially be at higher risk for hepatitis B, is that awareness efforts really, and just public health efforts in general, really need to be increased in a variety of different settings for sure. Um, and then one more thing that I found kind of striking was just about hepatitis delta, and particularly, thank you for bringing this up in your presentation. You're right, this doesn't get this gets spoken of even less than hepatitis B, but a 26% rate in Central Africa is very striking, and so yeah, I'm glad that it's rare to see testing for hepatitis delta done in Africa at all. So I know that these studies were kind of in the context of different, it seems like educational settings and different types of cohorts. What was there easy access to testing for hepatitis delta in these studies? Because I know that that's a big challenge in many settings in Africa.
my impression that it comes from academic researchers. I'm working with a Tanzanian group in West Tanzania, and basically patients would have to pay for themselves. The serum would have to be sent to Dar es Salaam, and we know actually that hepatitis delta antibodies. The main one was actually an Italian company. They had an assay, and at some point it was found it was not very reliable. The HDV RNA assay, which should tell us who should be treated versus not to be treated, is even more dicey. My understanding is that mainly it is home brew type of RNA testing in different universities. So hepatitis delta is an issue even in resource-rich countries.
Mhm.
Um, there's another thing that I want to say. Yeah, the fact how to reach out to immigrant communities, and I was hoping that uh, those on the call could give me some ideas. Just yesterday, I was in this picnic, a work picnic from a friend of mine, and there were several African immigrants, and I was asking them, "Is there a community center where you gather?" Well, I didn't see. It didn't seem that there was a lot of enthusiasm about learning about hepatitis B. And for instance, I tried to get in touch with a pastor here from Nigeria to try to see if they will be willing to have, a presentation to patients just on liver health in general. And I didn't get a lot of response. And also the issue that I asked some patients, some individual, and one person, actually a nurse, didn't think that mother-to-child transmission was a big issue. She thought that in Nigeria one was more likely to get hepatitis B via dental things or transfusions. So I was a little surprised by that, and I'm not sure how to reach out to the community. The Bronx study that I showed was important because they enrolled I believe there were three doctors that were from West African origin, and I think their credibility in the community was way higher, as I've been told here as well. To be credible in the Asian community, basically you need to be Asian or much closer to the community, and it's hard to establish this relationship.
Yeah, absolutely. If there are any audience members who have ideas for effective outreach, please feel free to share them. I think that, yeah, certainly working through some of the research that's been done at the Hepatitis B Foundation, working directly with community and faith leaders, and doing sort of train the trainer models to disseminate the information that way, and then have trusted leaders further educate communities is really helpful. And also coming to community events as well to do screenings wherever possible. That can be a little logistically challenging with the need for phlebotomy, but that can be, very, very effective as well. But I think, yeah, certainly with the Bronx study and the whole Starfish program at Montefiore in New York, I think has found great success with engaging community members and leaders. Like I think Fatima, who works there, has been really extraordinary in reaching many people to for testing and continuing to keep people involved and coming back for appointments and engaged as well, which is also, lost to follow up can be challenging as well. So. Um, but this has been really great. And thank you so much again for, compiling all of this information. We really, really appreciate it. And I think this is a great, I appreciate you also pulling in like socioeconomic factors and rates of affluence, how those can also, emphasize the intersectionality of hepatitis B in a large way. So thank you so much, and thank you for the work that you're doing. And I think when perhaps once you start more efforts in Tanzania and stuff, we can have you back to speak about those as well. So
Sure.
um,
I just wanted
yeah.
to shout out to Dr. Chitnis that I saw is in the talk because he's the one that basically pulled out all this very interesting data that I showed you about Alameda County. And even there, Dr. Chitnis has showed by looking at a heat map of even in a county, there are differences in the prevalence by pocket of probably reflected different immigration patterns. So yes,
Yeah.
a lot more work to do.
Yeah, absolutely. I think those heat maps are so effective as well in the level of detail that they can hone in on and can really help to identify forward directions. So yeah, so thank you so much again. And thank you to everyone for attending today. We really appreciate it. Again, apologies for the volume, but we can see if we can adjust that in the recording. We really appreciate, again, Dr. Bonacini for being here. And we hope that some of this information will be applicable to audience members going forward. Again, we'll share the recording and presentation with all webinar registrants. I'm going to put a link to the CHIPO website in the chat as well, so you can have more information about the coalition if you're interested. Um, and please feel free to reach out and get in touch with us using the contact information on the slide and visit our website for more information. You can always reach out to me directly again as well. And thank you so much again, everyone. And thank you, Dr. Bonacini. I hope you have a wonderful afternoon.
Thank you so much, everybody.
Okay, take care. Bye.